Thank you all for coming today. I want to give a particular shout out to Dr. Maya Maxim and Summer and Kelly and Greg and the ECHO group, the Alzheimer's Association, which supported the outreach that I'm doing with respect to the book I wrote with neurologist Dr. Bruce Miller at UCSF, and I'll talk a little bit about him. The Global Brain Health Institute, which is where I studied neurology for a year at UCSF. As I mentioned, Dr. Bruce Miller and my daughter, Sarah Weinstein, who uses some of those words that you were just talking about. So she was incredibly helpful with putting together this presentation. So with that, let's do the next slide, Summer. I thought I would begin by reading a small section of the book, Finding the Right Words. And I will be sort of talking about the book, but really talking about what I learned as someone who's not a neurologist, studying neurologist for a year, in order to write a memoir about my father, who developed early onset Alzheimer's with what's called the logopenic variant. So that's a word finding variant. And this happened in the 80s. He was in his mid 50s when we got the diagnosis, but he was clearly exhibiting symptoms way before that. And what I learned a word that I think is really helpful, the prodromal phase, which is when the disease is kind of percolating and not quite presenting itself fully. So I just want to just give you a little taste of the book, and then we'll move on. My dad worked incredibly hard. When I was little, he went to the office 6 days a week. And then as Apex Electrical Supply took off, the business he owned with my mother's brother, he worked 5 days a week, and then 4.5, so he could golf on Friday afternoons. I used to love going with him to the office and typing on the wide girth Selectric typewriter or answering the phone. Apex Electrical Supply, may I help you? Best of all, though, was getting to ride in the grimy van with him when he was delivering cables, wires, whatever. In those days, there weren't minivans or SUVs, so being in an elevated seat high up on the road counted as a novel experience, as fun. He liked to bowl and dance. His bowling day was Thursday, my mom's Monday. They liked to go dancing at the Meadowbrook Ballroom in Cedar Grove, the town next to Verona, New Jersey. At every bar mitzvah, he would try to teach me how to dance. He liked Robert Goulet, who starred in a 1960s Broadway show called The Fantastics, and sang Dad's favorite song, which was Try to Remember. Talk about foreshadowing. He also loved Cat Stevens' album Tea for the Tillerman and Roberta Flack's The First Time Ever I Saw Your Face. He wasn't materialistic, but he loved his Movado watch, a birthday present from my mother. No numbers, black face, and a diamond where the 12 would have been. He used to tell me I was afraid of my own shadow, and he was right. I was afraid of drying to death in a Maytag washing machine. Here's a list: The Dark, Clowns, Dolls Coming to Life, a Twilight Zone episode that I saw in Florida that scared the shit out of me for life. The Wicked Witch of the West, Her Skin, Her Laugh, The Monkeys. My third grade teacher, who was mean and sent me home from school because she said the gray and beige checked hot pants I was wearing, which my mother had bought me as a birthday present, were too short. The first time I saw my Nana without her dentures, I didn't know she wore dentures, terrified me. Her face was disfigured, wizened, collapsed in on itself. Speaking of teeth, I recall my father going to the dentist and consistently refusing Novocaine. The dentist would try to change my dad's mind by telling him how much the procedure was going to hurt, but Dad wouldn't be swayed. I don't think it was entirely about being macho, though he definitely relished narrating the pain and the sound of the drill, all while not under the influence. He would say that he preferred the pain to the numbness. Here's more. He had an Aqua Dodge Dart and he loved it because it lasted forever. Years later, he bought a Dodge Swinger, brown body, cream colored roof, and hated it. That's when I first learned that the word lemon could be applied to cars. He also hated raisins, which upset my grandma Sarah because she liked to make regala, a bite-sized Jewish dessert, with them. He loved Grandma Sarah so much that when he went on a golfing vacation with some of his friends to Bermuda, he took time out of the short trip to visit her in Miami. I remember him saying how happy he was that he had done this because it was the last time he saw her before she died. Dad was like this. He took care of people. He made sure my brother knew how much he was loved, even while he was becoming a Buddhist. He made sure that my sister got a dog after my uncle retracted on a promise to give her one from his friend's litter. I think he bought Taka and brought him home the day of my uncle's betrayal, or the next. The first time I saw my father cry was when he came home from the veterinarian, having put down Taka, our beloved dog of 13 years. I don't think I ever saw him cry about having Alzheimer's. At least I don't remember, but maybe I'm blocking it out. He loved my mother so much that when he got sick, she loved him back with all she had. And he loved me in ways big and small, in ways that make it necessary for me to write this book for him. Next slide. So my father was diagnosed in the 1980s with Alzheimer's. And in those days, we didn't have the kind of precision diagnosis that we have now. And so when I initially told you about what my father had, I said early onset Alzheimer's with the logopenic variant. And I got that diagnosis from Bruce Miller. And it was enormously powerful for me because Alzheimer's didn't sort of tell me very much about what he was experiencing. But now early onset is defined as dementia under 65. And the logopenic variant is a rare variant of Alzheimer's that focuses on word finding. So this was an enormous gift that Bruce gave me. And here's just a little bit about Bruce Miller. Maybe some of you in the audience know of him. His area of expertise with respect to sort of a specific kind of dementia is frontotemporal dementia, but he is extremely well educated in all the different diseases that go into a dementia diagnosis. And Bruce, along with some other scientists and researchers, developed what's called the Global Brain Health Institute. And it's really nice talking to this audience because I know it's so interdisciplinary. And this program that I was involved with from 2018 to 19 was an interdisciplinary cohort that included artists and doctors and neuroscientists and geriatricians, people who worked on dementia and dance, people who worked on dementia and architecture, thinking about sort of the horrors of some emergency rooms that a person with dementia might very well have to encounter, and how you can make those spaces more dementia friendly. Next slide. So Bruce and I both had certain goals that overlapped in coming together to write this memoir. I should say Bruce only knew my father through my memories of my father and through our conversations about my father, and through what I think of as an enormous act of empathy, was able to inhabit our family's experience of my father's early onset Alzheimer's. I was really committed to an interdisciplinary crossover. I think a lot of that had to do with growing up at Caltech. And I knew that not everyone sort of used Moby Dick and the Scarlet Letter as their go-to ways of understanding the world, but that cells and string theory and the whole vocabulary of science was a paradigm that really worked for many, many people. And so Bruce and I were committed to writing a book that would appeal to and resonate with as many readers as possible. So we wanted to make the science as accessible as we could. It's a sad story, so whenever humor is possible, that's integrated into the book. And I think as caregivers, whenever one can access humor, that can be extraordinarily helpful. I wanted to share my story in part to break down the stigma that is so attached to a diagnosis of dementia. And then the program that I talked about, Global Brain Health Institute, is very committed to equity. It's an international program. There were people in my year who were from Peru, South Africa, Ecuador, really all over the world. And a lot of people don't have access to UCSF or the Mayo Clinic or all of the Alzheimer's disease research centers that are doing such important work. And having Bruce be the other voice in the book was my attempt, our attempt, to give people who don't have access to state-of-the-art knowledge access. Okay, next slide, please. This is me and my dad. And Bruce, similarly, wanting to reach a general audience. He has a love of creative writing, and so the opportunity to share his story was really appealing to him. He stayed in the neurology lane for a really long time, and I kept on trying to get him to come over and sort of talk more autobiographically, which he eventually does in the course of the book, which I think makes it a stronger book. He wanted to share sort of a history of science regarding dementia. And he also, I'm skipping around a little bit, wanted to highlight the importance of empathy in doctor-patient interactions. Next slide, please. The issue of writing a narrative of dementia is, it's interesting and it's difficult. Bruce kept wanting me to sort of go back in time, and he would say, what came first? It was important to have an origin for my dad's disease. And I thought there were kind of two origins. One was depression. And Bruce said that, you know, people often think that sort of depression is a reaction to the disease. He thinks it's part of the disease. And so we talked a lot about depression and mood and word finding. When my dad was getting sick, I was a graduate student at Berkeley, so my relation with my dad was over the phone. And I noticed increasingly that my dad would hand the phone to my mom because he just was having difficulty with a conversation, difficulty with words. And so there's a way in which dementia, it's almost like an anti-narrative in a certain way. So the medical narrative is this happens and this happens and this happens and this happens. Like it tends to be quite chronological, but of course, memory is not chronological and grief is not chronological. And I really wanted to, in sharing my story, I was sharing the story of my dad's illness and my experience of it, and also my grief. So I didn't write the book till decades after he died, because I just, I couldn't. And now there are all these words for different kinds of grief, complex grief, anticipatory grief. Those words would have been helpful for me, I think, to understand why I was so stuck. And writing the book was extraordinarily helpful in getting me unstuck, and hopefully will help other people who are going through this experience. Next slide. I'm not going to read this, but I just, I think the slides can get circulated, but the book is several chapters. It begins with diagnosis and ends with memory. I actually thought it was going to begin with memory because when I started at UCSF, really all I knew about Alzheimer's was that it was connected to memory. I didn't know that that it was connected to mood and spatial disorientation and sort of physical manifestations. I just didn't know. So Bruce, basically the way the book works is I have memories of my father, his diagnosis, word finding, spatial disorientation, behavior, and then memory. I tell those stories from the perspective of a grieving daughter and someone who uses literature as a way to make sense of the world. And then Bruce responds, it's kind of a call and response. So in this excerpt, I had just talked about my father playing golf with his friends and aiming the golf club in the wrong direction. And how after that, people stopped asking him to play golf, and how excruciating that was, both for my dad and for my mom. And then Bruce talks about the role of stigma in his response to that anecdote, and talks about the importance of empathy, and basically says that my dad's friends lost an opportunity in cutting my father off and my mother off. So that's just an example of how the book works. Next slide, please. I'm going to go through this quickly. Finding Bruce took over a decade. I had to find a scientist who liked to write and who would make the time to write. Took a while. Figuring out the book structure was hard. Finding a publisher was hard because it was a memoir written by two people, one of whom didn't know the subject of the memoir. And so some people we spoke with, some agents, whatever, they were like, there's nothing else like this, so we don't know what to do with it. And from my point of view, hearing there's nothing else like this, that's a good thing. But the problem was, how are we going to do it on Amazon? What's the genre? What's the category? Next slide, please. And then for Bruce, finding time to write, and then only knowing my father through my memories. Next slide. The book is really committed to, and this is sort of one of Bruce's main contributions, to sharing in a way that any reader would understand sort of the complexities of dementia. And I know a lot of people use this umbrella image, with dementia as the primary category under which these various diseases follow. So we have images in the book like this, and I'm going to show a few others. On the book website, they're in color. We couldn't get the press to agree to do them in color, unfortunately. But we hope that when families talk to social workers, talk to neurologists, what have you, that they are ready with a vocabulary, that they don't hear the word primary progressive aphasia for the first time in the neurologist's office, that they've heard it before, and that there's a definition, and they can have more confidence going into the doctor's office. That was really important to me, to have readers just feel empowered when they go to the doctor, because the relationship is so hierarchical that whatever you can do to help the family feel like they can ask questions, that no question is too small. I think that can be really valuable. Next slide, please. Just this is another example of an image in the book, courtesy of some of the researchers at UCSF. There are just different kinds of aphasia. And as I said, my dad had the logopenic variant. And I think this is helpful because the doctor may say, oh, your loved one is suffering from non-fluent variant PPA. What? And then, this chart can help the family sort of, oh, right, that's what my loved one is saying. This is how they're trying to say it. And what's so amazing about precision diagnosis is that you can find the place in the brain that's being assaulted and know what kind of aphasia the person is experiencing. Next slide, please. Again, this is for the purposes of helping readers learn new words. It's just a very clear kind of geography of the brain. So when the doctor says, yeah, there's some deterioration in the temporal lobe, like as a caregiver, it's not going to make the deterioration go away, but it's maybe one less thing to be afraid of, one less word to be afraid of. Knowing where the temporal lobe is, I think it can be empowering. Next slide. So this is just a slide kind of rehearsing what I've already said, supporting readers with information. Just some of the things I found incredibly valuable studying neurology for a year. That there are sometimes indicators of a problem that if you intervene can delay some of the symptoms. So if you or a loved one is having difficulty with hearing, it could just be you need a hearing aid. It could be that it's a problem with cognition. And it's very good. Biden was able to get hearing aids over the counter. They're probably not as good as if you go to an audiologist, but they're better than nothing. My dad, one of his first symptoms was hearing difficulty. And he also had trouble sleeping. Maybe a CPAP machine would have been helpful. Certainly getting a sleep study would have been helpful. I've already talked about mood change and depression. He was sort of big pharma's dream come true. He was on an ungodly amount of medicine. Again, this was the 1980s and 90s, and the idea was whatever it takes to basically make the person easier to manage is what you need to do. Of course, some of the medicines he was given completely backfired. And at a certain point, it became difficult to know if my father's symptoms were a result of the Alzheimer's or a result of the medicine that was given to him. I often heard doctors say that like Haldol and some of these antipsychotics should be sort of an absolute last resort. I learned about the brain-body connection, which a lot of people are talking about now. What's good for the body is good for the brain. What's good for the brain is good for the body, vice versa. So, a lot of people are doing the Mediterranean diet. There's research to show that this can be really helpful for the brain. I learned about cognitive reserve. Um, and the importance actually, and this is such an equity issue, um, there's data to show that people, in lower socioeconomic areas, areas with a lot of pollution, um, the brain is not as developed as it should be, as it could be, that the cognitive reserve is not as robust as it could be. I didn't know any of this, and maybe most of you in the audience do, but if you don't, just passing it along. Next slide, please. When my dad was sick, my mom was basically given the diagnosis and told by the neurologist, goodbye and good luck. There was nothing about caregiving. And that has just been such a huge advance, I think, in the whole discourse around dementia. And Rosalind Carter, who, as we know now, has Alzheimer's, has this wonderful quote: there are only four kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. Next slide, please. And then again, on her website, she talks about what it means to be a caregiver. And if you provide support, such as errands and grocery shopping, wound care, medicine management, you deserve to be seen and supported. Next slide. So there's a lot here, and I don't want to go through it all because I want to make sure there's time for questions. And I've also covered some of this already. But just at the bottom, the word finding, it can be really hard. And one of the things I learned in writing this book called Finding the Right Words is sometimes you just need to throw out the words. It doesn't matter if the person knows the word or doesn't know the word. I mean, it matters to them and it matters to you because it makes you so sad. But sometimes, like, instead of playing a guessing game, just holding the person and just saying, like, I know this is really hard that you don't know the word. I don't know the word you're looking for either. So how about let's just let it go? And that can be really hard to do, especially in the moment. But I wish I had thought about that more when my dad couldn't find words. Having difficult conversations earlier, with respect to the diagnosis, quality of life discussions, do not resuscitate orders, advance directives. And these conversations can be forgotten. They can change over time. But I think as a caregiver, the more information you're able to get from the person you're caring for, the more confident you will feel as a caregiver. And maybe the person with dementia is waiting for that chance to have a hard conversation with you, but doesn't know how to introduce it. And so if there's a moment when something comes up that would invite a difficult conversation, go for it. I wish I had done more of that. So next slide, please. Just a couple of other things. Lots of people are talking about the power of music. Intergenerational connections can be really beneficial. This idea of, I don't want to lie to the person with dementia. I think that once upon a time, and I saw a video about this that was very hard to watch. This nurse was talking to this person with dementia who forgot that their mother died. And the nurse kept reminding the person with the dementia that their mother died. And then the person with dementia would experience that death and grief for the first time all over again. So I think sort of ways of deflecting. We can't see her today. Why don't we look at some pictures? That can be helpful. If the person with dementia like loves dogs or other animals, see if you can, keep that connection going. I think some assisted living places do allow dogs and cats. It's certainly worth asking. Next slide, please. So like I said, I want to make sure there's time for questions. Writing or journaling can be helpful, but if that's not your thing, being in a support group might be. I actually joined a support group a couple of years ago, decades after my father died, and it was a wonderful experience. I got to hear my mother's side of things, and she was so busy protecting me because I was in my 20s and she wanted me to get my PhD. She was so busy protecting me that she didn't really want to share her experience. And so hearing that in a caregiver group was just really amazing. And I learned a lot from those people. And I realized that many just had this high bar for themselves, that they had to be perfect. And that if they weren't perfect, they would just beat themselves up about it. And try to be patient, both with the person with dementia and with yourself. I think that's really crucial. Next slide, please. Oh, there was one other thing I wanted to say to caregivers, and that is make sure you go to your doctor appointments. It's really important that you stay healthy. And oftentimes when you fill out the form at the doctor's office, there's like a place for other. You should say you're a caregiver, because the doctor needs to know that. The doctor needs to know that, I mean, maybe you have two full-time jobs. Maybe you're, working outside the home or working inside the home and working as a caregiver. I just think that we sort of take this caregiving part as just kind of like not something that necessarily we want to share. But it's so important for your physical health and your mental health. So I would really urge you to communicate that with your doctor. Next slide, please. Yeah, so I've talked about this already. I left out the exercise part, but what's good for the body is good for the brain. Next slide, please. Here's just the table of contents for the book. As I said, I wasn't going to write about diagnosis, but Bruce said to me that diagnosis is so important. And he was right, because what I realized in writing that section was just all of the prodromal things that my father was exhibiting: hearing, sleeping, depression. And I'll just tell you this one story about the diagnosis. I referred to hearing aids several times, and there's a reason. I would go into Bruce's office and just tell him stories about my father's illness. Probably decades before my dad got his diagnosis, my mom took him to a hearing doctor. And the result was your husband's hearing is fine. And then the doctor said to my mother, "How long have you been married?" And my mother said, "Like 25 years. And the doctor said, "He just doesn't want to listen to you anymore." And I told Bruce that story, and he said that goes in the book. And I guess I share this because if you're with a doctor who's like that, find another doctor if you can. The experience with the doctor, I think, can be so traumatizing or so valuable. And if you don't have a good feeling about the doctor and your medical plan allows you to switch doctors, I really encourage you to do that. Next slide, please. Okay. I just want to say, actually, could you go back for 1 second, Summer? So the last chapter is memory, and I want to say something. This is for caregivers, especially. Writing that last chapter, memory, was really, each chapter was hard to write in its own way. The behavior chapter was hard because I wasn't there for a lot of my dad's behavior. I heard it through my mother, my sister, my brother. So that chapter was excruciating because it was a reminder of not being there and of the horrors of my dad's behavior, as I said, whether it was the disease or the medication. Writing the memory chapter was quite something because in the course of writing that chapter, I remembered my father before he got sick. And I talk about that because when he got diagnosed, it was like everything, the 25 years before that just disappeared. They didn't disappear, but they were too painful for me to remember. And so the memory chapter was me remembering all these wonderful things about my dad. And if you're having trouble remembering the happy things, the things you loved about the person with dementia, you might want to write them down. You might want to write down the things that made you really happy, that make you happy in the moment. You also might want to write down the things that are really upsetting you, because then if you write them down, like, you can't deny it. And denial is a huge thing. I don't want to get into that, but I'll just do the last slide and then take questions. So you know what? I'm not sure I should. Do people have a lot of questions? I'm not sure. I want to, Summer, what do you think? I want to make
Yeah,
sure
we
I
we actually have a case today that it's not
It's
really normal, but
perfect.
yeah, it's
is
perfect for
it
your presentation. So
okay.
So
we'd
let's
like,
leave this up so people
Okay.
can read it. But then
Okay.
there's a question, and I think it's quick because I think it's the answer is no.
Okay.
Claire says, can noting that you are the person with dementia's caregiver allow the provider to share health information with you?
Hmm.
And I think if you don't have a signed approval or from the power of attorney or the health forget what it's called. I don't think they'll share information with you, but if you're in the room helping, how can they not?
Right. I guess maybe, I think you're right. The answer is no, like, unless you have permission. And that could be one of the hard conversations that I was talking about. If your loved one has mild cognitive impairment, or even if you don't have that diagnosis, to say to your person, I think it would be really good if I got permission to know what's going on with you from the doctor. And you don't necessarily have to say why. I mean, you might be asked why by your loved one, but I think it doesn't have to be a big deal. It could be, but it needn't be. But it's definitely a conversation to be had.
Yeah, and so the power of attorney would have to give permission. But maybe we can make that a future presentation. So let's get clarity on that in a future week. Meg, are you able to share your case, which is a beautiful, perfect case for today?
Sure. Can everyone hear me?
Yes, and let me just remind the group what your questions are. How to diagnose, ideas for treatment, what resources are available, and how can I augment treatment? So we all got that on the top of the mind. Okay, go.
Okay. Okay. So my case study is on a 80-year-old mixed Japanese Chinese female who immigrated to the United States back in her 20s. And she and her husband ran a successful business together and raised 2 children away from their families in Japan. And the adult daughter suspected that something was wrong with her during a visit in the fall of 2014, encouraged the family to get her tested, but at that time, no one acted. And then this female was officially diagnosed with dementia in May 2016 when she scored 23 out of 30 on the Montreal Cognitive Assessment. I believe that's called the MOCA. Note that prior in October 2015, when the daughter took her to the PCP, she only scored 28 to 30 on the MOCA. So the doctor prescribed her Aricept 10 milligrams daily upon diagnosis and encouraged her to attend an adult day program, which she never attended. Her driver's license was suspended in February 2016 as she failed to renew. I think she forgot some of the paperwork, but the husband was convinced that the doctor reported her condition to the Department of Motor Vehicles and blamed the kids for it. So the 81-year-old husband is the primary caregiver, and adult son is married and lives about an hour away. Daughter lives out of state. So initially, all the family members were trying to be very involved in the care of this woman, but then the husband got very upset, told everyone to stop meddling and interfering in her care. An example was when she was tested for bone density initiated by the daughter-in-law, but failed to inform the husband about it. So he was very upset about that. And basically the husband has refused to discuss any legal issues as well as like advanced healthcare directives. So this member is slowly deteriorating and has increasing and significant memory loss and is now completely disoriented to date and year. There's difficulty differentiating what products to use for what reason. So examples using dish soap for hands or conditioner for her body in the bath, if she even remembers that at all. So at this point, she also now forgets to put toothpaste on her toothbrush like 80% of the time. So she needs to be monitored. She is still able to dress herself, but the husband does have to lay out the clothes for her every morning. She's extremely resistant to taking a bath. It requires a lot of encouragement. She's also unable to initiate any productive activities on her own and requires more supervision of ADLs as well as recreational activities. The husband has been the only caretaker since her diagnosis in May 2016. And he finally asked for help from his adult children so that he could go travel with a friend. And then he dealt with her safety throughout the pandemic. So both of them managed to avoid getting COVID. And so the doors finally opened for international travel, and he went on a 2-week trip to Japan in March of this year. And as he obviously desperately needed a break, he's slowly considering the idea of accepting outside help, such as like a home health aide, but as he actually refuses to place his wife in a care home. So diagnosis-wise, she has memory loss, dementia, hyperlipidemia, hypertension, although her BP can sometimes get low. I'll touch up on that on the med section, osteoporosis and scoliosis. As far as the current symptoms, so significant memory loss. She cannot remember conversation topics from several minutes ago, nor what she ate or recent activities. So every morning is like a reset for those of you folks who've ever seen that movie 50 First Dates with Adam Sandler and Drew Barrymore, she asks the same questions repeatedly every 1 to 2 minutes and doesn't recognize her husband in the mornings. And then as the morning progresses, and also this process is exhausting for the husband. So as the day progresses, her memory kind of starts to build up a little bit. And so she doesn't ask so many of the same questions. She does not have active suicidal ideation, but does often state things like, let me die already, as she is aware to some degree that her memory is failing. However, in her mind, she still believes that she cooks all the meals and still cleans the house and tends to other household duties. She's frequently misplacing items, so glasses, her purse, and has trouble placing like cups and plates and whatnot in the cabinet, laundry items in the proper place in the dressers and closets. So the husband no longer allows her to carry credit cards or anything of value in her purse. She wears a watch which has her husband's name and phone number because she doesn't like to wear jewelry. So wearing one of those ID bracelets or necklaces don't work with her. Husband gets frustrated as she sometimes puts away something with good intentions, but then obviously has no recollection of touching items and will even deny putting them away. She is easily confused and flustered, especially if she's stressed out or out of her comfort zone or routine. Sleep and appetite appear normal, although she does love to snack on sweets and will nap if she's not stimulated or not really supervised. Her diet is pretty healthy. Husband does the grocery shopping since she cannot drive, and he does try to create a diet that helps lower her hypertension and cholesterol. He also makes sure that she takes her medications every morning and night. No history of alcohol or drug use or smoking, nor any mental illness. As far as caffeine intake, she does drink 1 cup of coffee in the morning and Japanese green tea after dinner at night. No history of hospitalizations or suicide attempts. The husband encourages her to play golf 3 times a week for exercise and allows her to do food prep and wash dishes, but never cook on her own because that's a dangerous activity for her. And essentially going golfing is the only social interaction that she has outside of the house. But she can actually get jealous if the husband talks too much to the other female golf players. She prefers routine and would stay at home all day if the husband allowed it. And she also loves to sleep and averages 8 to 10 hours a night. She's also resorted to speaking Japanese most of the time, although she is fluent in English and Mandarin as well. So my question was, how can we get the husband to open up and discuss POA and legal guardianship issues, especially in the event that he should expire before her? And please note that he's an extremely private individual with the old school way of thinking, culturally still very Japanese, despite living in the US for well over 50 years. Also, any other suggestions on improving, both a quality of life for her as well as for her husband? And then the medications is the hydrochlorothiazide. I'm not sure how to pronounce that, but that's the one for blood pressure. But I guess he needs to check her blood pressure a couple times a week to make sure that it's not too low. The doctor told him to stop the medication if the blood pressure is too low. She's taking lisinopril, B12, calcium, atorvastatin, and donazepam, that's the Aricept, and Bayer low dose 81 milligrams, and then another medication that's every Friday for bones called aldendronate. So really the only treatments that have ever been tried, just the Aricept. he did inquire about this new medication that was approved by the FDA recently called, I don't know how to pronounce it, Liquimbi or something, but I think that it might be too late in the game for her because that is designed for early stage dementia, and I don't
Yeah.
think she's at early stage anymore.
No. So, Cindy,
Yeah.
we're not putting you on the spot here. We ask everybody for input, but from your description, she's lucky she gets to play golf with her husband, so nobody shuns her.
Right.
But it's too bad she doesn't have more outside activities. And it's good that he's actually asking for help. Sue says honoring their cultural values is important. So possibly, Dad, who would you want to make the decisions if you weren't available? If you're on your trip and something happens to Mom, do you want to have a backup decision maker? Do you know what she wants in case something happens to her? It's a hard discussion to have.
I have a question that he was interested in the Leqembi. I'm wondering about socioeconomic status, which informs a lot of what one is able to do in such difficult situations. And I guess I'm curious if there is money, to be crass, to have someone come in the morning, especially, it sounds like the morning is especially hard, just to kind of get the day off to a better start. So that's one thought.
Oh, yeah, on the socioeconomic, so we have quite good insurance in Hawaii. So I'm not sure what they're doing with the newest medicines because it is a controversial topic, right?
Right, yeah.
But pretty well, of course, they're insured through Medicare, definitely. But yeah, let's see. We got Kimberly says, what about an adult daycare? There are some that would honor the culture. Interestingly, I wonder if they have a church that has something or somebody could come in. Dr. Ware says using a watch as an ID bracelet is a stroke of genius. I had not thought of that before. Intergenerational care. Does husband have a good relationship with any provider? Maybe their PCP. If so, I suggest the family approach the provider and ask them to bring up the topics of advanced directives, the POLST, and perhaps the POA, etc. Oh, yeah.
It's Lena Jones from HMSA. So that was my suggestion. I just wanted to say, Meg, it's probably really important that whoever approaches the family, I hate to say it, but if they could be Asian, that would be really great. If they would understand local culture, that would be even a bigger plus. But this is a topic that's very close to home for me as my mom has Alzheimer's. So what we did was when she went through the stage where she was very combative with us and she didn't want to talk about, she basically kept saying, you need to record our conversations because you were not remembering what you said. So during that period, we actually worked with her PCP, who she likes very much, and had conversations with him about her care without a consent, because we were just giving him information, and he worked with her to get her to sign the consents. Once we had that in place, we then took the next steps to get an advance directive, get the POLST and put that up, post that in her house for the first responders. We now have a POA. We basically control all of her finances and her healthcare. So those conversations are tough to have with the individual because my father's been gone for years. So in this case, it's really kind of dealing with the grief of the husband, of the wife that he's lost, and of the retirement and the later years that he had expected. as well
Mhm.
as working with the family members and trying to hear their wishes. So that's why I suggested maybe if there is a provider that the children are comfortable speaking to, and the provider is willing to kind of take that middle ground perspective to get dad on board, that's a way
Mhm.
that they could possibly manage this whole scenario.
I'm sorry to keep
Okay,
everybody.
thanks, Lena.
Yeah, this is a really great discussion. Let's see. Michelle says that there's an adult daycare in Aiea. I'm going to say this wrong. Hongjuani. Um, very tailored to the Japanese culture. And she also says breaking the samurai way of thinking is going to be very difficult for the husband. So yeah, it's and then Sue says reevaluating her meds is also important. The liver finds it a challenge to metabolize more than 2 to 3 meds the older we get. I have seen some patients improve when deprescribing as appropriate. And actually that's interesting because I thought if I were in her position, I wouldn't want to take any meds probably, but I wouldn't really know to think about that. But the meds are life-saving meds. And if I'm saying, and I can see saying the same thing she's saying, let me go already. If something happens, because I've already said that to my husband, like, if I get like such and such, just, let me go. I've had a good life. Let me go. So I was thinking, I would just want to eat C's candy all day, which of course is ridiculous from a medical point of view, but Naomi says, suggest a geriatrics consult and team support. And Cindy says, I wonder if in the morning he can have a picture of himself on his shirt, something visual from the deep past that might help her. Oh, that's nice.
Yeah, there's a photo in
Okay.
their kitchen.
All right. And then Renata says, was vortioxine considered at any point? Some improvements in cognitive function have been noted from my research. Not sure in Alzheimer's. And it doesn't sound like it.
I don't know what that is. Or two.
Let's see. Vortioxine. And then an at-home palliative care program often has a team that includes a medical social worker who can hold and guide a family meeting to ask questions regarding care, including advanced directive pulse. This way, all the family can attend at their own home. Oh, that's a good idea. And then Maria says Project Dana is a nonprofit with the Caring for the Caregiver program. We work with family caregivers offering one-on-one counseling with MSWs who can guide through long-term care planning. Very nice. Vortioxetine is a selective serotonin reuptake inhibitor. Naomi says palliative care is a good idea. Unfortunately, all palliative care programs do not accept dementia as a primary diagnosis, of course. Oh, Ella's going to tattoo on her chest, do not intubate, do not resuscitate. And I believe her. All right. So we also offer REACH community training, one-on-one training for caregivers, caring for someone with dementia. Beautiful. Okay, so there are a lot of comments here. Let me hopefully we can download the chat and I can summarize it and send it to you. And then
Great.
yeah, next week, where did I see that? Oh yes, Heather Lusk is going to talk about Narcan fentanyl updates and resources. So she's from triple HRC, H3RC they call it. And any last questions or comments? I'm sorry we went over, but this is definitely a perfect case for today and the excellent discussion.
Appreciate the feedback to everyone.
And Cindy's slides are available on our ECHO resource page. the link to her book as well and her contact if you have any questions. Thank you for getting such a good conversation going and you're sharing your story with us, Cindy.
Oh, does Japanese culture include massage?
Thank you, Summer.
Doesn't- I don't know if it does.
Yeah.
Typically, they don't like
don't
to be
either.
touched.
Anyway, there's lots of thanks in the chat here. Thanks to Cindy for the interesting
Naomi's-
presentation and Megan for the case. Massage is big with Japanese. Okay. All right. Well, I will summarize all the comments and then I'll get them to Meg and then let's see if in a few months it's been helpful. So
Okay.
thank you so much, everybody.
Thank
Oh,
you.
shiatsu massage. There we go.
Shiatsu, that's right. Thank you, Cindy. All the mahalos
you
and
so
thank yous
much.
coming into the chat. Be
Yeah.
sure
Thank you
to
so much.
check
I
that
really
out.
appreciate
Yeah.
it. Thank you. Good
Thank
luck, everyone.
Thank you.
Okay, bye.
Thanks.
Have a great week. Dan's gonna be your facilitator next week because I'm gonna be on vacation.
Enjoy.
Thanks. Thank you, everybody. Have a great week.